It's my pleasure to kick off the afternoon session introducing Dr. Howard Frumkin, who will be our moderator. Dr. Frumkin is the Dean of the School of Public Health at the University of Washington, and he's joined on stage by our panelists who are going to be imagining a healthier city. And we have reading glasses. We have Christine Green, Strategic Partnership Manager of National Complete Streets Coalition and the former public health planner for Columbus, Ohio. We have Patrick Kinney, who's a professor of environmental health sciences and the director of the Columbia Climate and Health Program at the Mailman School of Public Health at Columbia University, and also William Lucy, professor of urban and environmental planning at the University of Virginia. Welcome our panel.
Thank you very much, Susan. And let me just call out and thank and salute the entire museum team, Chase, Susan, Scott, your whole team. You've truly made this museum a beacon for all those who are working on developing great places around the country, and we are very grateful to you. Thank you. Well, this session is entitled Imagining a Healthier City. Speaking of imagining, let me ask you to imagine for a minute that we're here as a convention of zookeepers. You're a zookeeper. It's a beautiful June day, and you get a call at the zoo that a shipment of frogs is about to arrive at the zoo. And your job is going to be to house those frogs successfully. So immediately your mind goes to their habitat. You begin designing a habitat for them. You're thinking about humidity and temperature and flora and fauna. At the end of the day, the metric that you care about is that that frog population thrives and is healthy. You know you've done well if the habitat supports that. Well, it's amazing how much we think about those terms with animals, but not with humans. I think most of us would agree that the most important outcome, or at least one of the most important outcomes of an intelligent city, is that the people who live there can thrive and be healthy and happy. That's what we'll be talking about in this session. So I'd like to begin by asking each of the panelists, from your point of view, we have backgrounds here in political science and urban planning and environmental health. When you imagine a healthier city, a healthy habitat in which people can thrive and do well, what do you imagine? Chris?
Well, my vision for a healthy city is one where people have safe and convenient options and able to access places on foot, by bike, and by public transportation. When I worked at the local level, I worked in urban neighborhoods that have great infrastructure but still have poor outcomes, and suburban neighborhoods that have poor infrastructure but only slightly better health outcomes. And so we need to make the physically active option the healthy and safe and convenient option.
Physical activity.
Physical activity.
Pat?
Well, I would build on that to emphasize providing interesting and fun activities for people in urban areas. I think one of the things that sets urban areas apart from suburbia, in my experience, is the accessibility to lots of fun things to do in a city, commercially, entertainment, open spaces. And I think for me, my vision of a healthy city is a place that has a lot of those things, a lot of those amenities, but at the same time makes them available to people in the healthiest way so that people can get to them without being exposed to lots of air pollution, without generating a lot of greenhouse gases that are going to be affecting the climate. And so both sustainability of the planet as well as health of the individual is maximized. And I think that's what cities really have the potential to do.
Bill?
Well, my answer is the same, at least at the beginning, which is that walking is the key. And if you have a walking city, you'll have a mixed-use city and a compact city, and those things all work together, as well as with other important conditions that were mentioned in the session on transportation and housing earlier. I'd like to do a partial segue to talk a little bit about cul-de-sacs, past, present, and future, because those have played such an important role in how built form has evolved, and they're such an important part of the challenge of adapting built form in the future. Perhaps the main incentive for the cul-de-sac, the no-through traffic street, was to provide a safe environment for families with small children, typically preschool. And I think that although the cul-de-sac has come to be seen as an obstacle to transportation, to walking, and to require turn a potential 100-yard walk into a 2-mile drive, to get from here to there, and therefore to put more people in cars for more reasons than they should. But I think at the same time that there continues to be, in part of many people, a belief that the cul-de-sac is safe, and in particular for small children. I think this is particularly important for parents of small children who tend to believe that and say that sort of thing at public hearings, so that whenever there's a public discussion about the development of a new area or the possible change in an existing area, the notion that the cul-de-sac is safe is very prominent in those discussions. And I argue the opposite, that the cul-de-sac is actually more dangerous than gridded through streets. And 2 or 3 reasons for that. The first reason is that I think small children are not well educated on cul-de-sacs because they have the image of being safe, and so parents are not sufficiently diligent in teaching them difference between street and sidewalk, if there is such a thing, and driveway and yard, and there's more confusion about what a safe area is. I think also that besides the fact that the cul-de-sac leads to more people driving for more reasons than they should, there's also a very potent fact about the actual cause of the most danger to small children. And that is that they are in the most danger of being backed over by somebody. And there's very little data about this because it's not collected by the national organization that's responsible for traffic safety. The reason for that is that they usually occur on private property, so they're not considered a traffic accident. And it's not hard to imagine that if most of these accidents occur in driveways, that the most likely perpetrators are the parents, right? And also, incidentally, the most likely types of vehicle that would be doing the backing over are the family-friendly vehicles of the SUV and the van. So I think we have these counterintuitive actualities which actually would be somewhat useful to mention by planners or others at public hearings when someone says, well, you're putting our children at risk by having a through street here. In fact, you can argue the opposite, I think.
So we've begun to sketch out the features of a safe habitat for humans. Opportunities to be physically active, clean air to breathe, opportunities for social interaction, safety from physical injuries such as car crashes. We've talked a lot in the first half of today about data. If you were going to design a dashboard, a data collection system to monitor how safe and healthy the urban habitat is for the people who live there, what would your dashboard look like? What data layers do you think we need to be collecting? Bill, you just mentioned data, so let's start with you and come back this way.
Well, partly because of the particular things I've looked at, I would look at fatalities, but I would also look at driving alone to work, because that data is available in the census, and it's a very good metric for all modes of transportation. Higher driving alone to work, the lower everything else. So I think by, rather than being too complicated, dealing with what's simplest, and that incidentally is available at the block level as well as at census tract and jurisdiction and region. So it's very useful. The data I've looked at that's particularly interesting to me is what I call the danger of leaving home. And phrasing it that way is useful in part because that approach gets one out of the silos that we're used to, and takes asks a more general question about what causes danger. And for danger, I use fatalities. And so the main dangers that I look at are traffic fatalities and homicides. But homicides are actually more likely to occur at home rather than leaving home. So I look at stranger homicides, homicides by strangers, which is actually only about 20% of homicides. So the interesting thing is, if you just do a simple calculation and look at the combination of traffic fatalities and homicides by strangers, you come up with the most dangerous areas are the ones which commonly are thought to be safest, which is the outer areas, because those are the areas, that is the outer suburbs or the exurbs, because those are the areas where the traffic fatalities are most frequent relative to population. And there are about a little more than 2.5 traffic fatalities for every homicide. And when you look at just 20% of homicides by strangers, almost all traffic fatalities, of course, are by strangers. You end up with a 13-to-1 ratio, 13 traffic fatalities to 1 homicide by stranger. And so from that, it's not hard to conclude that the most dangerous areas would be those with the most traffic fatalities, and those turn out to be the outer, supposedly safe areas.
So fatalities, travel behavior. Pat, what would you put on the dashboard for a healthy city?
I think from an environmental perspective, I think about urban areas from the point of view of air pollution and water quality. I think that water quality in most cases is pretty well handled, but air pollution is something that we've had a more difficult time controlling, particularly in urban areas where you're concentrating a lot of sources. Trucks, buses, cars, commuters, as well as other local sources, but particularly the traffic sources really dominate the exposures in cities. But until now, we really haven't had the data to assess the risk from the pollution that's coming from traffic. But new technologies are emerging for measuring air pollution at the local scale, and hopefully eventually at the individual scale. I'm hoping soon we'll have an application that can be incorporated into a portable device that a person can carry around, and to see what their current exposure is to fine particles. And I think if we did that, we would find that commuting actually is a major source of our exposure, because you're in the exhaust stream of all the other vehicles. And if we could know that, and if we could track our daily exposures, we might find healthier ways to protect ourselves, but also to start to think about what the sources are in our communities that are impacting our health. So that's one thing I would suggest.
Chris, how about you?
Well, at the National Complete Streets Coalition, we're starting to try to figure out a way to track the changes that are improving our built environment now. And so can we start to measure the number of improved intersections, new miles of bike lanes, new miles of sidewalks? I think if we look at a broader community perspective, it would be interesting to know the percentage of the community that has walkable, bikeable, or public transit access to destination places, that daily necessities, such as their grocery store or their school or their place of employment.
So pedestrian and bicycle infrastructure. Now, the epidemiologist and doctor in me is just screaming, nobody's mentioned looking at morbidity statistics. But if you look at a list of what the ailments are that trouble us most as Americans, anybody's list would include heart disease, cancer, asthma, depression, osteoporosis. Can you talk about the ways in which the built environment of the city either promotes or helps to prevent any of those conditions?
I'd be happy to jump in on that one, with a caveat that I'm not an expert on heart disease or other diseases of inactivity. But what I do know about it is that we have obviously an epidemic of obesity in the United States and in other developed countries. We also, along with that, we have an epidemic of diabetes. That in both cases are derived in part by decreasing amounts of physical activity in our daily lives, and partly due to changes in our diet over the last 30 or 40 years. But focusing on the physical activity aspect of that, I think that sort of building on Christine's comments and also Bill's comments, if we can certainly develop our communities in ways that promote individual activity to a much larger extent than we've been able to in the last 20 or 30 years. And To the extent that we can do that, that's going to be really good for health. And if we can get people out of their vehicles, their private vehicles, it means a lot less air pollution in the air. It means healthier air, while at the same time, people who are walking and bicycling are getting the direct benefits for their cardiovascular function. So I think this is one of the areas where there's tremendous synergies. And I haven't even mentioned the sustainability dimension of that. But you know, those individual motor vehicles, in addition to reducing physical activity, and in addition to producing local air pollution, are also spewing out carbon dioxide, which is the major driver of climate change. So we can have a sustainability goal that's being met at the same time.
Chris, Bill, any further thoughts on specific links between urban design and health?
Well, another one which is a little bit counterintuitive, that is a typical concern with traffic would be crashes and the desire to avoid them. And I think that's an example of a data type that can be very misleading. One would typically think, well, more crashes equals more danger. But in fact, that's not the case. What you want is more crashes, in the sense that where there are more crashes, there are less fatalities and less serious injuries, because the more crashes tend to be fender benders, because vehicles where there's more traffic are traveling at slower speeds. And so the places where there are fewer crashes relative to population, there also are cars traveling at higher speeds on two-lane roads typically. And so fewer crashes adds up to more fatalities and more serious injuries. And the fatalities have hovered around up or down from 40,000. They're generally more, but I think they may have just dipped below it recently. But the number of serious injuries or hospital injuries sufficient to go to a hospital are more in the millions range, 2 million or more. So, and those are directly related to speed. In fact, the speed, of course, is directly related to the danger to pedestrians as well. So whether in a car or out of a car, you want to be where there are fender benders, not where there are high-speed crashes.
And Chris, you focused on walkability and active transportation. What are the health benefits of those assets in a city?
Well, of course, we want to get people to be physically active and physically active in their everyday life. So it's not something that has to be scheduled in, that it's a convenient option that we're not even thinking about. And so we know that physical activity, helps reduce the risk of many of the diseases that you just mentioned, as well as improving the air quality and creates that sense of community, which is also very important for safety. And safety is a huge barrier to people wanting to be out in their neighborhood. But when people are out in their neighborhood, it encourages their neighbors to be out with them. It also is kind of the eyes on the street and creates a safer environment and fosters a healthier lifestyle.
All good points. Now let's think ahead 50 years. We heard mention this morning of the forecast that a substantial proportion of children being born now will end up having diabetes because of current health trends. If we look ahead 50 years, that's not the only trend that we have to be worried about. Climate change is occurring. We are probably at the peak of petroleum production, and petroleum availability will drop with time. Demographic changes such as aging and a more diverse population. How will all of those long-term trends combine to create health challenges for cities of tomorrow? And what kinds of thinking ahead do we need to do now to protect our grandchildren's generation when they live in cities?
This is exactly the question that our School of Public Health has been struggling with over the last couple of years, to try to look 30 years into the future and figure out what kind of public health challenges we need to begin preparing for and training students for. And that's obviously a very big, multi-dimensional question that we can't really answer here, but I can at least chime in from the climate change perspective, which is a topic that I study. One thing I would emphasize to the audience here, which many of you who are not scientists, is that the scientific community is essentially unanimous in believing that over the last 30 or 40 years, we're seeing definite signs of climate change. around the globe, and including in the United States. There's been substantial warming over the past 30 or 40 years. And unfortunately, no matter what we do right now, that's going to continue for another 30 or 40 years, although we can certainly diminish the impacts 50 or 100 years into the future. But those climate change impacts that we're experiencing already include heat waves in cities, something that is not new, something cities have been dealing with for a long time, but we're seeing bigger and longer heat waves. Also, Katrina gave us a glimpse of the future in terms of large storms. Not that we can say that Katrina was due to climate change in any sense, but we do know from climate science that large hurricanes are more likely in the future because of the warming oceans. So that's the kind of risk that cities that are along coastlines are going to need to prepare for and adapt to in the face of rising sea level at the same time. Another meter or so of additional sea level rise by the end of the century. So these are some really substantial challenges that cities are going to face. As I tried to allude to a moment ago in my comments about greenhouse gas emissions, cities can play a really important role in addressing climate change by taking advantage of the efficiencies of scale that cities present, the higher energy efficiency that cities have the opportunity to have, but also making that even better. And cities like New York, where I work, have been really leaders in thinking about sustainability and really setting targets for future sustainability. At the same time, trying to adapt to the climate change that we're already seeing and that we're going to have to deal with over the next 30 or 40 years.
Chris, Bill, what do you see when you look in your crystal ball?
Well, I'll speak a little bit about demographic changes and how they will affect who lives where, and in particular how they will affect the more vulnerable populations. Because I think we have another odd situation in the United States in which poorer people generally have captured the more convenient locations, which many would say are the better locations. And the richer people with more choices have tended to choose the less convenient locations. And there actually are trends that are well underway to change that. And in 2/3 of the large metropolitan areas, there's been a substantial shift in the last 20 years toward cities reviving as measured by income. And in fact, the decline of cities, which was often described as involving white flight, has been replaced by white return. And so in 2/3 of the large metropolitan areas of the nation, income of white non-Hispanics in cities, per capita income, is higher now than in suburbs. And median family income is almost the same. So the effect of that, looking ahead, will be, I think, that trend will continue. Cities will become dominated by middle and upper class people, vastly different than what we've been used to. And that lower income people will be steadily gravitating toward the suburbs. And that's okay in some respects, but it's also a problem because the suburbs have more accessibility problems, less transit, as was discussed in the previous session. And so we have huge challenges to change the means by which people get around. And better off people in the cities and those who are in certain locations farther out who want to come to the cities will be well served, but the suburban residents will not be well served. And in most of the country, those suburbs will have very small territories where they'll be dominated by the lower income population with low property values and low tax resources. So these are going to be enormous problems, I think, looking ahead.
Speaking of enormous problems, cities are very complicated places. There are many, sometimes overlapping, sometimes competing jurisdictions within a typical metropolitan area. And sometimes it's hard to know who's responsible for doing what. If there's a pothole in front of my house, I know that I call the streets department. But who's responsible for keeping the people of a city healthy? Chris, you've worked in city planning. Maybe you can take a crack at that.
So my position was as an urban planner in a public health department in Columbus, Ohio. And we really felt like it was everybody's responsibility to act as, health champions. And because we've seen research that shows that almost every built environment decision is in some way affecting health. And so we need to apply that health lens throughout all of our city departments. It should not be siloed. And the way that Columbus Public Health dealt with it is they created the Healthy Places program. And my job was to insert that health lens into the planning and the transportation and the building services department. And there was great outcomes that weren't very hard. So for instance, I started participating in rezoning review and reviewing rezoning applications, looking for opportunities to increase the walkability and bikeability of a site. And it was only, we were only dealing with that one site. We weren't dealing with a larger scale plans, but just by asking nicely if a developer would include some extra walking and biking features, 64% of developments did over a 2-year period. And so there's definitely some easy ways to start to have public health partner with all these different departments, and it doesn't have to be hard. It doesn't have to be another layer of bureaucracy. It's just working together and figuring out what existing processes there are and how to insert that health lens.
So asking nicely works in Ohio. Does it work in New York City, Pat?
It's hard for me to judge, actually, but New York City, as you know, has had a very strong health department for a long time. I think it may have been the first health department in the country, at the city level, and I see very strong leadership coming from the Department of Health. Although I think their jurisdiction is limited to the confines of certain issues that they can deal with, and if it comes to a land use decision or a building design certification kind of question, I'm sure that goes beyond their jurisdiction. So I guess there's a need for some kind of coordination, and in New York it seems like that comes kind of from the mayor's office. And he's, Mayor Bloomberg's been a strong leader in that sense, and he's a strong advocate for public health. So I think in that special situation, we've benefited by coordinating all those city agencies in a way that may not be that common, in my view.
Well, health department obviously is important, but to the extent that the built environment affects health, the agencies that affect the built environment are also very important. When I left the Planning Commission in Charlottesville, Virginia, a couple of years ago, I said to my successor, one of the important things you need to understand is that the fire department plans a city. And that was a slight exaggeration. But the fire department, of course, is concerned with health, dangers of fires, and the injuries and deaths that can occur from them. And they, of course, take that very seriously. And so we have, because of that, we have an example of a stovepipe or a silo thinking. And so in a site plan review process or a subdivision review process or a zone change process, the fire department would be at the table of staff at a very early stage discussing what should happen with this proposal. And they would tend to argue for a wide intersection with a gradual corners to make it easy to turn their very large vehicle into a cul-de-sac that might be 100 feet long or 200 feet long, 36 feet wide at least, so they can drive around at the end and back out. But of course, in doing that, they've contributed to, if they succeed, a difficult to cross intersection. And one of the classic problems with the fire department, at least from some points of view, that contributed to the movement in some states, like New Jersey in particular, for rehab codes, rehabilitation codes, was a problem like this, that the fire department, in reviewing the proposed change of an office building to an apartment building, would say, well, if you're going to do that, you have to create exits that are safer than the ones you had there for the office building that was built in the 1920s, let's say. Well, if you change the stairways and widen them substantially, then you're going to change the internal wiring and everything that's in that wall and so on. And so the effect was that this was often not feasible financially. And so the outcome of that was a vacant building, which of course is not safe. And so you get these, again, these counterintuitive outcomes from a well-intentioned perspective aimed at a particular outcome, which doesn't take into account the interactions among department responsibilities and overall effects.
So if it's the case, as we all seem to agree, that upstream decisions have a huge impact on health, land use, transportation, energy, and so on, are some of the most important determinants of health in the city. And if it's the case that our systems of government tend to be very stovepiped, and even our disciplinary boundaries are fairly non-porous, how do we get health professionals to work together more effectively with planning and design professionals and vice versa? Both of you are in the educational business. You're both at universities. Are there educational or other techniques that we can be using to get more health professionals to engage with planning and design, and to get more planning and design professionals to think about the health consequences of their work?
Yes, certainly that's true. One can do that. At Columbia, just as an example, I guess for the last 10 years or so, there's been a fairly robust collaboration between the School of Urban Planning and Architecture and the Public Health School. In fact, we have a joint master's degree program that some students have taken advantage of, and we just, one really good example was a student who graduated last year with a PhD in urban planning, but she had done her master's in public health previously and had worked in urban planning as well. And she did a very innovative thesis looking at neighborhood features and how they impact on heat wave vulnerability during extreme heat in New York City. And so I think training people at the undergraduate, graduate levels to work across disciplines is something that we can try to do at universities, because we have those different disciplines that can be accessed fairly easily. And get, having students in the same classroom who come from different schools, who speak different languages, I have found very interesting and very productive in creating that dialogue. So what they do once they go out is another matter, and I hope that foundation will promote the kind of effective policy that has to come later.
At the University of Virginia, we've just created a Center for Design and Health between Architecture and the School of Medicine, which you happen to be on the advisory board for, I believe. But I also have a specific proposal at the professional level, which is that the American Public Health Association and the American Planning Association collaborate, as they did in 1948 in creating the Planning the Neighborhood document, which was renewed without change in 1960. I don't believe it's occurred since then. The 1948 document seemed, from looking at the roster, perhaps to have had more planners than public health people on it, but both were represented, and the publisher was the American Public Health Association. But that was focused entirely on building new communities. And I think we really need one that's focused on adapting existing neighborhoods or jurisdictions. And that doing that would bring in the other participants in local affairs, not just planning, but the fire department and others, who would also be at the table, and that would be one way of both recognizing and perhaps overcoming some of the silo effects which are so common in most aspects of governance.
Before we open to questions, let me turn to one other aspect of public health that's very important here. We've talked a lot in today's meeting about data, about how intelligent cities, intelligent systems make data readily available. But those of us in public health know that people don't make all their decisions based on data. Sad but true. People make decisions for lots of reasons, sometimes in a data-free zone. For example, 1 in 5 Americans now smokes. We can be pretty sure that those 1 in 5 smokers know that smoking is not good for them, but they've made a decision to smoke for other reasons. When it comes to intelligent cities, when it comes to the configurations of cities that we think will be not only healthy but sustainable and prosperous, what are the ways in which we might take health education insights and apply them so that people begin developing preferences, knowledge, attitudes, and ultimately behaviors that will drive us toward intelligent, healthy, sustainable cities? How do we change popular culture? Chris, you've worked in a health department.
And you know, I think coming from a health department, we know that, you know, the behavior change is not easy, and that we have to change the built environment and at the same time work with people to use that built environment in the way that we want them to. And so I think it's, you know, it's again making the healthy choice the easy and convenient choice and safe choice as well. I'd be interested to hear what the other panelists had to say.
Well, you know, you're right. Behavior change is notoriously challenging, and the smoking example is a really good one. But as was mentioned in some of the earlier panels today, I think the choices that individuals have among transportation options and among residential options, up to now have been limited by incentives and subsidies from the government in certain directions. And I think by just changing the subsidy structure, the incentivizing the healthy choices, there's a lot of room for behavior change because I think there's a demand for having options for transportation that go beyond private vehicles. I think people would want that, but it's but if the option's not there and it's not if it's not safe, affordable, and reliable, then it's not going to happen. And so there needs to be investment in creating the choices that then allow people to make a healthy choice. So that's one thing I would mention. I think that there is though there's a larger educational need for sort of shifting Americans' views about, or their understanding, I guess, about what sustainability means in connection with their own daily lives. And that's a bigger issue that's going to require some really hard work. How do you find a way to get people's attention and let them understand the connections between the choices they make in their daily lives and larger sustainability issues, which they may well care about, but they don't see those connections. And to the extent that data can be helpful in that regard, if we know how much energy you're using each day, how much water you're using each day, those kinds of things could probably help. That would be a component towards driving the kinds of the knowledge base that individuals need to begin making better choices and to change the paradigm of their thinking.
So to take you back just one moment, do you think that some of this built environment debate can be reframed as a health debate? Can it be? Should it be? Would it help to move the needle if people thought of these issues as health issues?
I would think so. In fact, I've thought that for a long time. People health is a really strong driver of people's action. It's a strong driver of congressional action, federal action. So if we can illuminate the health connections, and I don't mean make them up, I mean let's just study them and understand them and quantify them. I think that information will provide not only empowerment for the individual, but also political capital that can be used at the highest levels as well.
And I definitely saw that at the local level where the different departments wanted to work with the health department because health was kind of a neutral argument. Nobody can tell you that we didn't have bad health statistics, or nobody wanted to be the person standing up saying, you're lying about, the horrible obesity rate. And so the transportation department was glad to have me on board because I was another kind of advocate for what they wanted to do, but with a different level of different argument.
Let me invite anyone with a question to begin to move to the microphones, and same for those out in cyberspace. And while they do, Bill, did you have a comment to make?
Yeah, well, I think the behavior change which has the most sweeping potential is the decision about where to live, which is actually why I've focused on danger and death, because those tend to be vivid enough to get people's attention. And the desire to avoid that is certainly influenced where young parents choose to live, and usually young parents choosing a location having schools in mind and would like to stay in the same school district and with the same set of peers for a good number of years, and perhaps through high school. Unfortunately, there are not enough parents of young children who are sufficiently aware that young children grow up to be teenagers, and there's nothing more dangerous than a teenager in a car at after midnight on a two-lane road, having had a little too much to drink, and so on. But there's both a reason why I also emphasize the back-over deaths of small children, but there's also a cultural obstacle here, which is, and I'll give you an example. 1 month ago in the local newspaper, there was on page 2 of the local section, there were 2 paragraphs about a child, age 5, had been injured, perhaps seriously, when backed over in a driveway in an area 10 miles south of the city of Charlottesville. There was no follow-up story, there was no information about what happened, and then a week later, there was another 2-paragraph story, same location, second page, which said that the child had died. And there was no indication as to the conditions, no mention of a name, no mention of an address, no clarification as to which parent had backed over the child, though it seemed clear that one had. And obviously this would not have happened had there been a death that had occurred someplace because of a ricocheting bullet or some other direct cause. But this was a sufficiently ambiguous ethical question from the newspaper's point of view. They didn't quite know what to do with it, and so they did just a tiny bit, but virtually nothing. And so, in fact, this was a teachable moment which was missed. And I think it's another example of how the culture isn't quite ready to figure out how to deal with this. And that also goes to the back-over deaths in general, because the National Traffic Agency has not collected those data, and maybe they've changed very recently, but it would be very recent if they have changed. So
a call for more and better data, but also more and better narratives and stories about things that happened to bring those facts before the public. Yes, sir, would you identify yourself and go right ahead?
Sure, my name's Ed Gilliland. So my question is bicycling really healthy? You know, I understand the cardiovascular benefits, but you're also biking, you're at the very bottom of the food chain. And I do have people I know that have been in pretty serious bike wrecks. And so I like to think we're Copenhagen, or we could be Copenhagen, but it seems like we're a long ways till biking is really healthy.
So a question about the balance between the health benefits of bicycling and the safety threats of bicycling. Chris, you have been very involved in Complete Streets, and you've thought about this issue.
Yes, and I don't have the specific data, but the health benefits of bicycling are clearly, great. And the more that we could pass Complete Streets policies and be creating those built environments where it makes it safer and there is space for bicyclists, and that we can give awareness to drivers that they have to share the road, we'll continue, to make it safer.
Do we have examples of American cities that have moved toward better bicycle infrastructure, either with dedicated bike lanes or with bike boulevards or other methods, that have produced data showing improved safety for bicyclists?
we do know that when the infrastructure, the answer is those examples do exist, and I don't know if I know them specifically. We do know that when we have the infrastructure, it is safer. We do have research that shows that it is safer when we, create a built environment that works for all modes of transportation.
Well, can I answer that? Two cities that have made a lot of progress, and it's reflected in the mode share, the percentage who are biking to work, are San Francisco and Minneapolis. And I think they're particularly interesting because San Francisco has a few hills, as you may have heard, and Minneapolis is a little bit cool. But both, despite being inhospitable, have made major efforts to identify safe routes and to build safe routes, and to work at developing a culture that is more supportive in a variety of ways at the destination and as well as along the way. And they've gotten their mode shares up to 2%, I think, in the case of San Francisco, and 4%, which is very large for an American city, in Minneapolis. So I think some significant progress is possible, even in the United States.
So suggestions from various cities, and you didn't mention, but you might have the European comparisons, suggesting that what seems to be a trade-off between safety and health need not necessarily be that trade-off.
Right.
Yes, sir. Oh, let me go to this side. I didn't see people over there. Go ahead.
I'm Sarah Williams from Columbia University, and I'm currently writing a research paper and doing research about data and policy. So I want to get back to the question about data. And one thing I was thinking about while you were talking about is how the New York City Department of Health, they're a leader in using data to affect policy. Amazing amount of research, analysis, and one of the things that I always think about is that their ability to use data analysis to really do on-the-ground kinds of work, whether it comes to promoting vitamin D in neighborhoods. And I'm wondering what lessons can be learned from the health department's use of data for other departments. How is it that New York City's health department and other health departments are really successful at using data to implement policy, but other departments aren't? And I thought maybe because you work in the health field, you might be able to respond to that question.
Mm-hmm. Mm-hmm. I know one of the limitations that we saw in Columbus was that we were losing zip code level or specific, smaller than zip code level data, because you had to oversample, and if you didn't have the funding, you didn't get that data, which is very important data to have to make some specific, decisions. I think that it goes to political will and having somebody that's willing to stand up and say that health matters. It's very convenient to keep health out of the decision-making, policy-making conversation because you don't have to deal with the tough questions of health and equity or, traffic safety. And so I think it takes a very strong health department to want to publicize their data, have the correct data, publicize their data, and get into those decisions and stand up and make the link that, health does affect a lot of different built environment decisions and a lot of different policies.
Yes.
Clark Larson, City, Rocco Planning. I was just seeing one theme of this event as finding out what some of the outlets and access to information are as being important for creating an intelligent city. And I was wondering if you could comment a little bit about what outlets public health can provide, information on public health can provide to the public, how they can use it, whether you see this happening in cities today. What are good venues that this can be presented to the public?
Our chair here may be able to say a lot more about this, but a lot of cities with funding from the Centers for Disease Control have created data portals in their departments of health to put up all sorts of health-related information, some of it environmental information, some health statistics in more or less real time as part of a large funding program through CDC for data tracking. I don't know much about it. I know that New York City is one of those places, and they have a pretty nice portal with a fair amount of data. Who's using it and how effective it is, I'm not really sure.
I guess I would just add, taking off my moderator hat for a moment, that health data are relatively widely available through health departments, but one of the challenges is to link health data with other data, such as transportation data, residential data, and so on, so that we can draw conclusions about factors that are impacting health. And that's one of the big challenges. As you just heard, there is a CDC-funded program to encourage those data linkages at the state and local level, but we have a long way to go as a nation. Yes?
My name's Amelia Greiner from the Johns Hopkins Bloomberg School of Public Health, and I had a comment on how to better integrate land use decision-making in public health, and mostly wanted to make a plea that people not wait until the APA and APHA collaborate on a giant report, or that we develop new curriculum for students, although I believe that's very important, but that people with a public health background, attend their local planning meetings. I've just been involved in evaluating Baltimore City's zoning rewrites, and public health was not involved prior to our group's involvement, and the amount that public health experts can bring to just helping people in the planning departments understand what public health terms are, bringing in dispossessed community perspectives, understanding mental health impacts is enormous, and that we can all bring quite a bit simply by attending, and through those informal collaborations build things that help to develop public health partnerships and growth that are separate from a full curriculum overhaul or something like that. And I just would be interested in your comments as public health professionals and researchers about the possibility of doing something like that more widely. Thank you.
Thank you. Responses from the panel?
I think it's a really good point.
Yep. You have full agreement. Yes, sir.
My name is Perry Coalfield. I'm an architect over in Arlington, Virginia, and I wanted to throw out kind of a futurist question, which is maybe the intelligent city really the smaller city? And I'll tell you what I mean by this. I think the theme of this entire fascinating seminar has been essentially how humans will cope with these increasingly large cities with all of the problems we have been talking about. But is there any possibility that you all have seen in your data that would indicate that there could be a repopularity of smaller cities? And I mention this because we have a professor from Charlottesville and someone from Columbus, Ohio. And I'm not sure that this migration is all necessarily going to be one way forever, simply because one of my oldest friends in the world, for example, is from Canton, Ohio, and they have a lot of problems in Canton, Ohio, and North Canton and whatnot, but they are sort of different problems than the big cities are dealing with. So, you know, if you had a country that actually got to work again with working factories and whatnot, is there any chance that all of these trends that we're talking about would begin to reverse?
Mm-hmm, mm-hmm. Well, I will say that at the National Complete Streets Coalition, Complete Streets policies require that when a street's designed, it's designed for all users of all abilities. And we're seeing those policies adopted across cities. And a third of our policies are adopted in smaller towns, 30,000 people or less. And so it's clear that no matter where you live, that you want this ability to be able to walk and bike as a part of everyday life, which then means you want the destination places, and you kind of want that neighborhood feel and smaller city feel, no matter where you are. So I don't necessarily have a comment about the trend, but I know that it's desirable.
We're just about at time, Bill, so a short comment, please.
Two comments very briefly. One is that for 30 or 40 years, that when people are asked where would you like to live, the most popular place to say, at least, is small towns. Second thing I'd say is that Charlottesville, which is a city of 40,000 plus a little bit, in a metropolitan area of 180,000, but with very few commuting problems, had a transition over the last 15 years that occurred exactly in 2003, measured by price per square foot, where the city of Charlottesville became more valuable based on price per square foot than the very affluent outlying county around the city. And I think it's because of walking and has continued since then. So the values in the city are about 15% higher per square foot than in the county of Albemarle.
Well, I think we're just about at time. We've talked about some of the features of healthy, wholesome, sustainable human habitats. We've identified some of the health consequences when our habitats don't measure up. We've talked about some of the strategies for making places healthy places, ranging from policy interventions to social marketing to environmental change. And lastly, I think by demonstrating this interaction on the podium and with all of you, we've shown that the intelligent city is a city where we break down silos, where we have health professionals talking with design and planning professionals. And over time, if we keep on doing that, we will get it right. Please join me in thanking the members of the panel for a wonderful conversation.